Hello, this is Kim Jong-il. Today's topic is reproximation in non-extraction treatment. Reproximation is also known as interproximal reduction, slenderizing, stripping, and enamel reduction. Reproximation is the removal of a small amount of enamel from between the teeth to reduce their width. For example, in case of lower anterior crowding, the interproximal areas can each be reduced by 0.5 mm, resulting in a total of 2.5 mm of space from 5 interproximal areas in anterior region. According to Peck and Peck in 1972, tooth reproximation is a clinical procedure involving the reduction, anatomical recontouring, and protection of the mesial and/or distal enamel surface of a permanent tooth. Reproximation is most commonly performed in the mandibular or maxillary incisor area in patients with a tooth size discrepancy, especially when there is an anterior Bolton ratio discrepancy and lower anterior crowding. Reproximation can be performed to align the lower anterior teeth. In general, there are many cases with anterior Bolton ratio higher than 77.2%. With normal value of 77.2%, the upper and lower incisors can have proper overjet and overbite relationship. However, if it is higher than 77.2%, it indicates lower anterior crowding, upper anterior spacing, or shallow overjet and overbite if neither lower anterior crowding nor upper anterior spacing exist. There are two main benefits of stripping. 1. Point contact is changed to a broad contact surface which increases contact stability and reduces the chance of relapse of crowding. 2. Increase available space in the lower anterior area for alignment of crowded teeth. However, there are potential problems of reproximation. 1. Worsening of tooth width. Height ratio. 2. Long clinical crown. Therefore, the patients should be informed that teeth can appear longer due to worsening of width-height ratio. In other words, long clinical crowns of the anterior teeth is a contraindication of reproximation. In 2000, Kokich discussed certain principles before making the decision for reproximation. First, anterior Bolton discrepancy. Second, triangular crown shape of the incisors. Third, the root width is relatively narrow if the crown shape is triangular. Reproximation would be an inappropriate treatment if the root width is broad. Fourth, sufficient amount of interproximal enamel. Potential side effects were discussed as follows. 1. It may cause the mandibular incisor roots to approximate excessively, resulting in thinning of the interradicular alveolar bone, perhaps masking it more prone later periodontal bone loss. 2. Another potential side effect is the resulting enamel roughness that may contribute to increased plaque accumulation. Crown shape and interradicular bone thickness should always be evaluated in reproximation. Thin interradicular bone in the lower anterior teeth is a contraindication. There should be considered in clinical application of reproximation. 1. Amount of reduction. 2. Susceptibility to caries and periodontal disease. 3. Enamel reduction technique. Generalized stripping of the entire arch is advocated by J.J. Sheridan to relieve crowding without extraction. According to him, up to 0.3 or 0.4 mm of enamel can be removed per tooth surface, depending on the size and shape of the teeth. 1. Amount of reduction: 50% of interproximal enamel can be reduced. So 0.5 millimeter from each anterior contact and 0.8 millimeter from each posterior contact can be reduced to gain space. From 5 contacts of the 6 anterior teeth, 2.5 millimeters of space can be gained. Between the first molars, 7.6 millimeters of space can be gained. Between the second premolars, 5.7 millimeters of space can be gained. In the anterior teeth, the amount of stripping is equal to the amount of retraction. So reduction of 2.5 millimeters corresponds to 2.5 millimeters of retraction. The enamel surface becomes rough if it is untreated after reproximation, so it is important to polish to smooth surface. 2.1. Susceptibility to caries. There is still a lot of controversy over the susceptibility to caries in reproximation. Some claim that caries susceptibility increases, but others believe that there is no significant difference due to remineralization of tooth surface. Nevertheless, even development of a single caries can be a serious problem, so I perform reproximation only in adult patients. That is, it is not recommended in growing patients, even though they have good oral hygiene control. In growing patients, bonded retainers can be placed on the anterior teeth, and crowding may develop when bonded retainers are removed. When these patients become adults, partial orthodontics of the anterior teeth with reproximation can be carried out. 2.2. Susceptibility to periodontal disease. In lower anterior teeth, the root proximity can increase the susceptibility to periodontal disease. 1. It is better to perform reproximation after the alignment. Many orthodontists do it before in order to gain space. However, I recommend to first align the teeth and then perform reproximation step by step after alignment at even contact points. Here, if tooth 12 is crowded, the 3 contact points between teeth 11 and 21, 21 and 22, and 22 and 23 can be reduced first. And then the contact points around tooth 12 can be reduced after alignment. In adult patients, tooth alignment often causes labioversion, especially in the lower anterior teeth. Reproximation can be performed after alignment and labioversion. However, in some patients, labioversion can lead to gingival recession. So in order to minimize the chance of gingival recession, reproximation can be performed step by step, starting at even contact points. In this patient, it is recommended to reduce the contact points between teeth 33,34 and 43,44 first, and then around tooth 32 after it is aligned. 2. It is appropriate to perform reproximation after Class 1 canine key is established. Even though the teeth are decrowded, reproximation before achieving Class 1 canine key may lead to improper overjet and overbite. Therefore, canine key should be assessed during decrowding, and overjet and overbite are evaluated after Class 1 canine key is obtained. If there is a lower anterior crowding, reproximation on the lower anterior teeth is recommended. But if there is no lower anterior crowding, it is advisable to build up the upper lateral incisors with resin rather than reproximation of the lower anterior teeth. According to the literature, it is recommended to use separation strip with etchant and finish with polishing. There are many devices for reproximation. A. Perforated diamond-coated disc. B. Soflex XT disc. C. Ortho strips system is used a lot recently. It is easy to use by connecting to low-angle handpiece. D. Super snap, finishing and polishing disc. E. Smallest diamond point burr and sandpaper can be used in case of severe black triangle. These steps should be followed to resolve black triangle. Many orthodontists reduce only from lingual to buccal direction in the occlusal side as in step 3. Instead, 1 first reduce from gingival to occlusal direction in the lingual side and then 2 in the buccal side. And 3 finish in the occlusal side for proper reproximation. F. Finishing strips should be used after reproximation. The enamel surface can be polished by finishing strips with etchant. As a result of reproximation, the incisors move posteriorly. Is A or B better in this tooth movement? In A, the amount of reduction on buccal and lingual sides are equal. In B, there is more reduction in the lingual side. B is the proper way of reproximation. In order to do so, the lingual side can first be reduced with diamond point burr. This patient has a crowded upper right central incisor. In case of crowding, insufficient amount of reproximation in the lingual side results in unesthetic incisors that appear to have spaces between them. Keep in mind that there must be more reduction in the lingual side. In many cases of black triangle, the incisor crown shape is triangular and it can be reshaped into square crown by reproximation. Especially when there is a black triangle between the upper central incisors, it has to be removed by reproximation and space closure. This patient with lip protrusion was treated with the extraction of upper and lower first premolars. The lips were retracted by a large amount, but too many black triangles were formed. Black triangles and triangular crown shape of the upper central incisors were overlooked during diagnosis. Although the patient demanded more retraction of the lips, but it would be inappropriate in terms of dental health. These are post-treatment photos of cases of A. U44, L44 extraction, B. Reproximation, and C. U44, L55 extraction. In case of adult patient with triangular crown shape and lip protrusion or crowding, reproximation should first be considered as a treatment option. Thank you for watching.